Hello, my name is Kat Hamblin, and I'm here to present The Unnamed, a quality improvement initiative for anonymous trauma patients. Our objective is to describe a safety issue related to trauma patients admitted anonymously, identify the root causes, apply the PDSA model to address the problem, and then examine the role of the advanced practice nurse and how to implement this initiative. In trauma settings, especially in Phoenix, patients are arrived anonymously by the trauma nurse, and sometimes without belongings or photo identification. This can happen for a number of reasons. Maybe it's an active crime scene and police are still processing it, or the patient was not carrying any form of identification. When a patient comes in anonymously, we can't access their medical records, cannot see what their allergies are, or even know their name to look them up in the emergency health record system. That makes it extremely difficult to deliver safe, personalized care, and it sometimes delays notifying their families. Oftentimes, family members are waiting in the waiting room for hours and aren't even sure if their loved one is in the ER or may have been transferred to the OR or ICU. In a diverse city like ours, where cultural or religious factors might influence our care decisions, such as the inability to receive blood product or end of life preferences, these delays can have serious clinical and ethical consequences. Patient identification errors are often systemic and can impact safety, care quality, and family communication. When we can't identify a trauma patient right away, it may delay critical treatment decisions. We might hesitate to administer certain medications or even blood products without knowing their history or preferences. Usually, we treat to save lives by any means necessary upon arrival. However, any pause or wrong decision can mean the difference between stabilizing a patient or missing a crucial intervention, or it can even have a lasting impact. And it's not just the clinical consequences, it's incredibly hard on these families. Imagine sitting in the waiting room, not even knowing your loved one is there, or even learning after the fact that they passed away and no one can notify you appropriately to be at the bedside. It can be heartbreaking. It can increase stress for trauma nurses who have to balance managing patients, uphold their privacy, and practicing trauma informed care at the same time. There are so many layers to why this happens. Police can often hold personal belongings for evidence, especially in violent crimes. EMS may not receive updated paperwork from nursing homes or their care facilities. And even when patients come from home, there's no documentation with them. It's a systems level breakdown that plays out at the bedside. Even minor identification gaps can lead to diagnostic and treatment errors with cascading ethical consequences. For this quality improvement initiative, I selected the PDSA model, Plan, Do, Study, Act to start with because it's flexible and highly effective in dynamic environments like the emergency department. It allows us to implement changes in real time and then evaluate what's working and what needs to change. In the plan phase, I outlined my goal, in this case, improving patient identification time. Then I would implement small changes in the do phase, observe the results during study, and then refine that approach in the act phase. So to start with the support of the plan phase, I used the 5 whys tool to dig deep into the root causes of delayed identification. That analysis helped me expose exactly where communication and system breakdowns were occurring, like with EMS, law enforcement, and missing identification, or the inability to use other systems to identify the patient. Together, PDSA and 5 whys gives us a structured yet realistic way to improve outcomes in high-pressure trauma cases. PDSA supports structured, real-time improvement, while tools like the 5 whys uncover root causes of system inefficiencies. To help define the root cause of our delay in patient identification, I use the 5 whys method. This tool was applied during the plan phase of the PDSA cycle and helped expose multiple breakdown points, from EMS documentation gaps to police evidence holds and lack of nursing facility paperwork. By asking why 5 times or even more, I was able to get past surface level issues and identify systemic delays in workflow and communication. This clarity allowed me to build targeted, realistic solutions and laid the foundation for the steps and metrics that followed. To fix this delay, I've outlined a straightforward but coordinated set of steps. First, I need registration and social work to be involved immediately, not after the patient is stabilized, but the moment a trauma alert goes out. Once EMS calls our patch phone, either a trauma nurse or charge nurse will assess the trauma criteria, and from there we will send out alert in our ER in a page. That way, someone's already working on identification while care is being delivered. Second, we use Care Everywhere to search regional electronic medical records for any previous patient visits in the area. That means photos, allergies, and even potential next of kin can be within those records for us to help identify them. Next, we can help EMS to be more supported with better tools and expectations. That includes submitting any digital versions of paperwork or medication lists from nursing facility or their residences. It's something we can turn on quickly and build into our trauma protocols. The measurable goal, identify the patient within about 1 hour of arrival. So that's going to require real-time coordination between trauma teams, social work, EMS, and our registration support. We plan to pilot this within 3 months, update our trauma audit tool, which we currently already use, to include timeframes, and then we can reassess monthly to fine-tune that process, as well as discuss any barriers in our unit at the unit-based trauma committee meetings. This way, everyone is informed, everyone can provide feedback, and any issues that they may have can also be implemented or rethought of. To help bolster the identification process, we can then tap into the technologies we already have in place. Like I mentioned, that starts with Care Everywhere. This lets us scan for past medical records, photos, and contact info in local hospital systems that use Epic or even Cerner. It's a quick way to potentially link an anonymous patient to an existing chart. If we even have partial information, it can lead us to the next step. We can also work with Access, Arizona's Medicaid system. If a patient has ever used state-funded healthcare, there may be a photo or identifier on file that we can access in collaboration with registration and social work. Usually there's a driver's license or another photo that helps staff compare the pictures to the patient for identification purposes. In some cases, though, particularly violent crimes, law enforcement can assist with fingerprinting if the patient is part of an ongoing investigation. Sometimes that can be a useful last resort for ID confirmation. However, this process may take a while if we have to wait on the officer that is trained to complete this process, as they could still be on the scene. At Honor Health John C. Lincoln, every trauma patient record is audited. These audits include documentation on how quickly a patient was identified, whether the triage was partially or completed, and whether next of kin was reached in a timely manner. That data is compiled into a trauma metric dashboard and shared with our unit-based trauma council and used for hospital accreditation purposes. John C. Lincoln is a level 1 trauma center and also a magnet designated hospital. So we constantly use metrics to assess what we're currently doing and how that measures up to our hospital system level and the national level. So moving forward, we'll track metrics like the percent of patients identified within 1 hour. So our benchmark goal can start at 80% of patients. That average time to next of kin contact, we could set a benchmark goal of 30 minutes. And the percent identified before death or escalation of care, say going to the OR or ICU, benchmark goal can be ID 95% before that escalation. These data points will help us fine-tune the intervention and keep the process accountable. For this to work, we need full buy-in across the trauma team. This isn't a solo effort. It starts with a trauma nurse practitioner and attending who leads bedside decisions and coordinates with residents and other departments in real time. Then we've got ED nurses and techs who are hands-on with the patient, the trauma nurse who is initiating the anonymous account and often notices some small clues about identification like tattoos or clothing brands. Registration staff are also responsible for merging anonymous accounts with actual patient accounts after checking Care Everywhere or Access databases. Our social workers can help in and assist with next of kin tracing and help provide any culturally sensitive care once the patient's identity is confirmed or suspected. EMS crews can help by bringing nursing facility paperwork or patient information from the field, and that can take collaboration within the nursing facility leadership and EMS. And finally, working with our law enforcement partners who may be holding critical information like ID or fingerprints due to the investigation processes to help identify any potential safety risks if patient is identified. So on top of that, we really need to look at this as a system-wide support need, like updating HIPAA guidelines that clarify what can be shared in emergencies, full EMR access for cross-referencing charts, and updated trauma protocol that supports ID work from minute one. This initiative can only work if all parts of the system are in sync. So, as an advanced practice nurse, we can play a central role in this initiative, not just clinically, but administratively as well. So, first and foremost, we can lead that ID protocol at the bedside, directing team action in real time. Whether that's triggering that EMR search or collaborating with police and social work, we're the hub for communication and decision making. We can also advocate fiercely for our patients' rights, especially when they can't speak for themselves. That may include respecting cultural preferences like religious beliefs that might affect consent or treatment decisions. As Lippi et al. 2017 pointed out, even small missteps in patient ID can escalate into diagnostic or ethical errors, which we're here to prevent. Outside the ED, we lead education sessions for EMS and our nurse facility partners. That might include training EMS on transmitting paperwork digitally, or even the nursing facilities on importance of sending face sheets during transport. These can even be faxed ahead of time. Finally, we serve as a bridge between clinical care and that hospital leadership, ensuring the needs at the bedside are reflected in protocol, QI metrics, and system-wide trauma policy. As Amzudi et al. Described, advanced practice nurses are critical to leading PDSA-driven change that's both realistic and impactful. To evaluate the effectiveness of this initiative, we can start with monthly audits. We can track metrics like the average time to identify a patient and the percentage of next of kin contacted within 30 minutes of arrival or within 2 hours. From there, we'll use feedback loops with EMS and social work to identify recurring barriers so that we can adjust our approach. Every quarter, we can bring these findings to our trauma council to update protocols and strengthen system-wide consistency. And for that long-term sustainability, this workflow can be added to new staff orientation and annual training so that that rapid identification becomes an embedded expectation, not a reactive solution. This initiative doesn't just improve workflows. It forces us to grapple with serious ethical questions around privacy, identity, and protection. On one hand, we want to be transparent with families and act quickly, but on the other, we have to protect the safety of our patients, especially in cases involving gang violence or undocumented status. Revealing a patient's identity too soon could put them at risk. That's why we emphasize non punitive reporting when ID is delayed. That isn't about blame, it's about identifying a system gaps and keeping patients safe. We also have to uphold those HIPAA laws while being mindful that sometimes emergency exceptions apply, especially if disclosure could impact life saving care. And above all, we're making space for culturally competent care, whether that's respecting blood product refusals, gender based care restrictions, or spiritual practices. In the chaos of trauma, that ethical lens matters just as much as the clinical one. Thank you all for listening, and if you have any questions, please feel free to reply with any that you may have.